Hello, my dear students. I'm Dr. Anupama Chowdhry Devgan, your physiology faculty. You can find me on all social media handles as Dr. Anupama's Physiology. This is time now for the INICET November 2025 Physiology Recall. So let's have a look at the first question. It says, which of the following is not seen in Conn's syndrome? What is Conn's syndrome? This is primary hyperaldosteronism. What is the function of aldosterone? Aldosterone increases sodium reabsorption. It increases the potassium and the H+ secretion. Where are the aldosterone receptors present? These are present in the collecting duct, in the salivary glands, in the colon, sweat glands, hippocampus, and recently they have also been discovered on the heart and blood vessels. So if there is a hyperaldosteronism, we expect an increase in sodium reabsorption. This will cause the plasma sodium levels to increase. But along with increased sodium reabsorption, there will also be a water retention. This increases the ECF volume, resulting in hypertension. So hypertension is definitely a feature of Conn's. Hypertension will be seen. What will happen to the plasma potassium levels? Aldosterone will increase the potassium loss in urine, producing a hypokalemia. What about the H+? Aldosterone increases H+ secretion in urine, causing an alkalosis. So by exclusion, what we are not going to see is hypernatremia. And this is very easily explained. Along with sodium reabsorption, there is a water retention, which sort of causes a dilutional effect, plus the effect of aldosterone escape. Whenever there is increase in ECF volume, there is increased secretion of, plus whenever there is an increase in ECF volume, there is increased secretion of atrial natriuretic peptide, and that causes a natriuresis. This is the mechanism of aldosterone escape. So out of these four, what is least likely to be seen in Conn's syndrome is hypernatremia. Let's see the next question. It says increase in the height of the LV pressure volume loop as shown in the figure occurs due to an increase in which of the following conditions? Actually, the loop was something like this, where there is increase in the height of the LV pressure volume loop without any change in the stroke volume. Stroke volume is the width of the loop. Now, what is represented on the y-axis is the pressure. So increase in height of the loop means that the LV has to exert more pressure to pump the blood into the systemic circulation. So what are the conditions which can cause an increase in the height of the LV pressure volume loop? If there is an increase in the afterload, more the afterload, more the pressure exerted by the left ventricle, causing an increase in the height of the loop. So my answer to this is going to be A. What is the afterload for the heart? Afterload for the heart is the total peripheral resistance, or also known as the peripheral vascular resistance. If there is an increase in the ventricular contractility, what is going to happen? Increase in ventricular contractility will increase the height of the loop, without a doubt. It will also cause an increase in the width of the loop, increasing the stroke volume. So this is not the answer. If there is an increase in the venous return, what do I expect? I expect the end diastolic volume to increase. If the end diastolic volume increases, 0.1 as represented in this diagram will be shifted to the right. So I get a tall and a wider loop, because you know that more the end diastolic volume, more will be the force of contraction of the ventricle, which is known as the Frank-Starling's law. So there will be increase in the height as well as the width or the stroke volume. This is what you see during exercise, for instance, or an increased sympathetic discharge. So this is not the answer. If there is an increase in the aortic compliance, we expect that the height of the loop, in fact, will reduce, because as the blood moves from the left ventricle into the aorta, if aorta is more compliant, that means that it is easily distensible. So the LV has to exert less pressure. So we expect a decrease in the height of the loop. So the answer to this question is A, increase in peripheral vascular resistance, or the afterload. Next, during inspiration, a decrease in the systemic arterial pressure occurs due to which of the following? There is a fall in the systolic blood pressure, but this fall in the systolic blood pressure during inspiration is usually less than 10 millimeters of mercury. If the fall in the systolic blood pressure is more than 10, we call it pulsus paradoxus, which is typically seen in cardiac tamponade. But this question is asking you, why is there a fall? Is it because there is a decreased venous return to the right atrium? During inspiration, there is in fact an increased venous return to the right atrium, but this is not the answer to this question. Increased right ventricular filling? Yes, during inspiration, there is an increased right ventricular filling. Is there a decreased left ventricular filling? Yes, there is a decreased left ventricular filling during inspiration. There are two reasons for this. Number one, because of increased right ventricular filling during inspiration, the interventricular septum bulges to the left, decreasing the left ventricular volume. And number two, during inspiration, the pulmonary veins, which are intrathoracic, they tend to distend and hold more blood. Why do the pulmonary veins distend? This is because the surrounding intrapleural pressure during inspiration becomes more negative, tends to distend the pulmonary veins, which now hold more blood, decreasing the flow of blood to the left side of heart. Is there a decreased pulmonary compliance during inspiration? No, there is increased compliance of the pulmonary veins. Increased pulmonary vascular resistance during inspiration? Yes, you do see an increased pulmonary vascular resistance, but that is not the answer to this question. Is there an increased systemic vascular resistance? Systemic vascular resistance is not related to inspiration. So out of B and C, what is going to be my better answer? The better answer is a decreased left ventricular filling. That is the main reason why there is a decrease in the stroke volume, decrease in the systolic blood pressure during inspiration, but this decrease in the SPP has to be less than 10 millimeters of mercury. Huntington's chorea. What were the options? I've not got a recall, but I expect what is the lesion. In chorea, the lesion is in the caudate nucleus. Remember, C for caudate, C for chorea. If there is a lesion of the globus pallidus, it gives rise to athetosis. Slow writhing movements are seen in athetosis. If there is a lesion of the substantia nigra pars compacta, it gives rise to Parkinson's. If there is a lesion of the subthalamic nucleus of Lewis, it gives rise to hemibalismus. So, a lesion of the caudate nucleus gives rise to chorea. Which of the following represents the most stable and long-term mechanism of homeostasis? Another recall said that the question is, in a stable patient, the best indicator of adequate homeostasis with zero error is which of the following? Now, the homeostatic mechanism, which has got a gain of infinity, an error of zero is only one in the body, and that is the maintenance of the arterial pressure by the renal body fluid mechanism. Kidney has a regulatory mechanism with a zero error. So urine output is going to be the best answer. Serum magnesium level is mainly maintained by which of the following? Now, is it going to be dietary intake, renal regulation, intestinal absorption, or bone metabolism? The best answer here is renal regulation. Almost 70% of the magnesium in the plasma is filterable. 30% is bound and 70% is free. This is a freely filtered ion. Now, all electrolytes, sodium, potassium, chloride, bicarbonate, calcium, are mainly absorbed in the PCT. 60% or 2/3 of these electrolytes will be reabsorbed in the PCT, except in the case of magnesium. The maximum magnesium reabsorption occurs in the thick ascending limb. Now let's have a look at the sites of magnesium reabsorption. What is the percentage? What is the mechanism? In the PCT, like I just told you, all ions, all electrolytes except magnesium are maximally absorbed in the PCT. Maximum magnesium absorption takes place in the thick ascending limb. Now, the mechanism of magnesium reabsorption is passive in the PCT. This is by a phenomenon of solvent drag. Water and dissolved solutes move between the cells, which is known as solvent drag. In the thick ascending limb, again, it's a paracellular reabsorption, but this is driven by a lumen positive potential created by the leak of potassium. So let's have a look at what is this lumen positive potential. So this is a cell of the thick ascending limb. What do we have on the basal side is the sodium-potassium pump, which pumps out 3 sodium and brings in 2 potassium. On the luminal side, you have a Na plus K plus 2Cl minus co-transporter, which is also called NKCC2, sodium potassium chloride co-transporter. Now the potassium which enters the cell, it leaks out back into the lumen with the help of what are known as the ROMK channels, renal outer medullary potassium channels. Sodium leaves the cell by the sodium-potassium pump. Chloride will leave the cell via a chloride channel, which is called ClCKB. This chloride channel is associated with a protein which is known as Bartin. Now, present on the basolateral membrane is a protein which is called CASR, calcium sensing receptor protein. This senses the level of the plasma calcium and plasma magnesium. And this, in fact, has an inhibitory effect on the NKCC2. So that means if there is an increase in the plasma calcium level, it will start inhibiting the sodium-potassium 2Cl minus co-transporter. Likewise, if there is increase in magnesium level in the plasma, it will inhibit the NKCC2. If NKCC2 is inhibited, there will be less reabsorption of sodium potassium chloride. Now that positive potential, which is created by the leak of potassium, will not be there. Now, what is the importance of this positive potential, which is created by the leak of potassium back into the lumen by the ROMK channels? This potassium, which is present in the lumen, will now cause the calcium and magnesium present in the tubular fluid to pass between the cells. It repels these cations and causes their paracellular movement between the cells. So that is why this leak of potassium back into the lumen, back into the tubular fluid, is important for the reabsorption of calcium and magnesium. So let's see this. Mechanism of Magnesium reabsorption in the thick ascending limb is paracellular, driven by the lumen positive potential created by the leak of potassium. This is the major regulatory site, and it is going to be affected by the plasma magnesium level. As I just told you, if there is increase in the plasma magnesium level, it will be sensed by the CASR, which starts inhibiting the sodium-potassium 2Cl- co-transport, decreasing the magnesium reabsorption. The loop diuretics will also cause decreased reabsorption of sodium-potassium chloride. Again, that positive potential created by potassium will not be there. Calcium and magnesium will be lost in the urine. In the DCT, another 5 to 10% of magnesium is going to be reabsorbed. This is a transcellular reabsorption with the help of a channel which is known as TRPM6, transient receptor potential M6 channel. The epidermal growth factor increases TRPM6. So if there's a drug which inhibits the EGF, will reduce magnesium reabsorption. Parathormone will also increase the magnesium reabsorption. So serum magnesium level is mainly maintained by the renal regulation. Let's have a look at the next question. It says transport protein which uses ATP out of the cell is likely to be which of the following? Was there an image given? I'm not sure about that, but let us see a transport protein which is using ATP. Can it be SGLT1, which is sodium glucose linked transport? Now, this does not use ATP. It is an example of secondary active transport. Secondary active transport is dependent on the activity of the sodium potassium pump, but it does not use ATP directly. So this cannot be the answer. GLUT2. Glucose transporters are examples of facilitated diffusion, which is a passive transport, does not use ATP, so this cannot be the answer. Organic anion transporter protein. This is an example of anion exchange, which is also passive, does not use ATP. So by exclusion, my answer is P-glycoprotein. Now, what is this P-glycoprotein? It's a pump which uses ATP, and it drives substances out of the cell against a concentration gradient. Now, where are these P-glycoproteins present? What are these? Now, P-glycoprotein is an example of ATP binding cassette transporters. It is also known as ABCB1 or MDR1, multi-drug resistant protein 1. Now, where is it present? It is present in the intestinal epithelial cells. It pumps the drugs back into the intestinal lumen. It is present on the canalicular membrane of hepatocytes. It secretes drugs into the biliary canaliculi and in the bile. These are present in the PCT cells. They pump the drugs back into the urine. Endothelial cells of cerebral capillaries. They pump drugs and substances back into the blood, limiting CNS penetration. In the placenta, they pump the substances back into the maternal blood, protecting the fetus. What is the clinical importance of the P-glycoprotein? So it helps to maintain these different barriers, like the blood-brain barrier, which we know is formed by the tight junctions between the endothelial cells of cerebral capillaries. The P-glycoproteins do not allow substances to pass freely into the brain. They help to maintain the placental barrier. As I just told you, they are present in the placenta. They limit the movement of substances towards the fetal side. They pump the substances, drugs, etc. back into the maternal circulation. Now, another very important clinical importance of the P-glycoprotein is that there is drug resistance to certain anti-cancer drugs like doxorubicin or vincristine or paclitaxel. That is because of these P-glycoproteins. They pump the drugs out of the cells back into the circulation, not allowing these drugs to act on the tumor cells. Then substances such as verapamil, drugs such as verapamil, quinidine, cyclosporin, they inhibit the P-glycoprotein. So they affect the pharmacokinetics of other drugs. So P-glycoprotein becomes important as far as pharmacology and pharmacokinetics is concerned. This is an ATP binding cassette transporter. Next question. In myasthenia gravis, repetitive stimulation of a nerve causes a decremental muscle response. Which of the following is the most likely explanation? Now, here it says it's not asking us about the pathology of myasthenia gravis. It says, if I do a repetitive stimulation, I find that there is a decremental muscle response. That basically means with repetitive stimulation, the muscle weakness worsens. Why does the muscle weakness worsen with repetitive stimulation in myasthenia gravis is because of a depletion of acetylcholine. The pathology in myasthenia gravis is that there are antibodies against acetylcholine receptors on the postsynaptic membrane. But with repetitive stimulation, we find that there is a decremental muscle response, or the weakness worsens. This is because with repetitive stimulation, there is a exhaustion or depletion of acetylcholine from the nerve terminal. So there is a bit of a controversy here that could the answer be B, could the answer be C? But remember, B is actually the pathology of the myasthenia gravis. Here it is actually asking you, why is there a worsened response, or why does the weakness worsen with repetitive stimulation? The answer to that will be C. Which of the following neurotransmitters is incorrectly matched with its site of synthesis? This was probably a question which had multiple correct options. Now, raphe-magnus nucleus secretes serotonin is from raphe-magnus nucleus. This is absolutely correct. Norepinephrine is from the locus ceruleus. This is also correct. Dopamine from substantia nigra pars compacta. This is also correct. Acetylcholine from the nucleus basalis of Maynard. Nucleus basalis of Maynard is cholinergic. This is involved in arousal, attention, in learning, memory. Acetylcholine from nucleus basalis of Maynard is also correct. Nucleus basalis of Maynard neurons are affected in Alzheimer's, in dementia. So all will be correct. I'm not sure if there was a difference in the options that were given, but if these were the options, then of course all are correct. Now, which hypothalamic nucleus is primarily responsible for leptin resistance? We know that the hunger center is the lateral hypothalamus. Ventromedial nucleus is the satiety center. The answer here is neither lateral or ventromedial. It's in fact the arcuate nucleus, because leptin, which is secreted from the adipocytes, acts on the arcuate nucleus. The paraventricular nucleus is basically involved in the integration of these impulses. Paraventricular nucleus is involved in the integration of signals from the arcuate nucleus. So answer to this is arcuate nucleus. Now, what does the leptin do? Leptin from adipocytes acts on the arcuate nucleus. There are two types of neurons in the arcuate nucleus, the POMC or the CART neurons. POMC is pro-opiomelanocortin, and CART stands for cocaine and amphetamine related transcript neurons. They decrease appetite. Whereas the second type of neurons in the arcuate nucleus are NPY, which is neuropeptide Y, AGRP, agouti-related peptide neurons, and these are orexigenic, or they increase the appetite. Leptin acts on the arcuate nucleus, and it affects the POMC or the CART neurons to decrease the appetite. So leptin produces a sense of satiety. Now, in leptin resistance. There may be high leptin from adipocytes, but it is not able to act on the arcuate nucleus. This could be due to an impaired transport, or there are some inflammatory changes which have happened in the arcuate nucleus. So it is not able to act on the arcuate and decrease appetite. So leptin resistance will be due to its inability to act on the arcuate nucleus. Which of the following secretions has the lowest sodium concentration? Now, sodium is reabsorbed and potassium is secreted in the salivary glands, and aldosterone increases this. It increases sodium reabsorption and the potassium secretion. Sodium reabsorption occurs in the salivary glands as also in the colon. So the best answer here is going to be saliva. The 2025 Nobel Prize in Physiology and Medicine was awarded for which of the following discoveries? This is a completely factual question. Recently it has been declared, and so T-cell immune regulation. Sodium absorption is least in which of the following? If this was the question which was asked, now the answer to this will be the stomach, because stomach is not a primary site of absorption. What is the main function of the stomach? Is a churning action. It helps to decrease the size of the food particles by a churning action. So absorption is not the main function of the stomach. So sodium absorption will be least in the stomach, maximum in the jejunum. Identify the agent blocking the transporter sodium potassium ATPase pump, digoxin, which is derived from ouabain. There is an ouabain binding site on the beta subunit of the sodium potassium ATPase pump, and digoxin will block the sodium potassium ATPase. Tall A wave. A wave is due to atrial contraction, C wave due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. X descent is because of atrial relaxation and because of a downward pull of the closed tricuspid valve into the right ventricle during the ejection phase. V wave, another positive wave due to venous filling of the right atrium just before opening of the tricuspid valve. And then you have the Y descent, which is due to flow of blood from the right atrium into the right ventricle during the first rapid filling phase. What will cause an increase in the height of the A wave? That means the right atrium is exerting more pressure to pump the blood into the right ventricle. This will occur in tricuspid stenosis. Patient has severe acidity. Imaging shows a small nodule on the medial side of the second part of the duodenum. Which of the following is likely to be increased in this patient? There is acidity. This is definitely a situation of gastrinoma. That means there is excessive secretion of gastrin. This is the Zollinger-Ellison syndrome. 70% of the gastrinomas are found in the first and the second part of the duodenum. 30% pancreatic head and peripancreatic tissues. This is called the gastrinoma triangle. First and second part of duodenum, pancreatic head, and the peripancreatic tissues. But the most common site is the first and the second part of duodenum. So these were the INICET November 2025 recalled questions. I hope you got most of these correct, if not all of them correct. Thank you very much, and all the best.